Welcome everyone to the AKT High Yield Revision webinar for the October AKT exam. For those that haven't met me before, my name is Muhibur Rahman. I'm a portfolio GP and a consultant in medical education. So I've been teaching and helping people get through membership exams now for coming up to close to 20 years now. Okay, joining me today on the faculty to help answer the questions and deal with the query, we have Anna Greathead from the core eMedica team. So in terms of the format, we're going to go through 15 exam style questions covering key topics, followed by rapid reviews. You'll see examples of questions from stats, admin, and clinical. So we're going to split this into three parts. So part one, we'll do 5 interactive questions, 55 seconds each. You'll have 55 seconds to look at the question. Then I'll launch a poll. Once you see the poll, select an answer, and then we'll go through explanations and teaching. Part two, we'll do a timed 10-question mini-mock, just to get you used to managing your time for optimum timing. Then part three, we'll talk about how to make the most of this period. We've got exactly 8 weeks to the next exam, what to do in that period, and then there'll be a chance for a Q&A. So use the chat as you've been doing since it was enabled for comment and discussion. If you've got a question, use the Q&A for that. And Anna will be picking up questions as we go, and any that are left over, I will deal with at the end. We've got a dedicated session for that. So we're going to go straight into the first question, okay? So you'll have 55 seconds once you see the question, and then I'll launch the poll. You won't see or hear me during the question so that there are no distractions, okay? Here we go. Okay, that's your time now. So just in terms of what people picked, the main split really was between A and C. So the hearing in the right ear is mostly in the normal range, and it's consistent with a conductive hearing loss in the left ear. They're the two things that most people picked. Okay, a few people did pick the other options, but A and C are the two important ones. Okay, so the correct answer is A, that the hearing in the right ear is mostly in the normal range. Now, any question with a picture in it in the exam, make sure you look at both the picture and the scenario. So if we look at the scenario, it mentions a 38-year-old engineer, and they're having an annual check as part of their work. So you can think, about the kind of thing that might lead to someone having to have a hearing test as part of an annual check, that there might be a risk there of certain things. That's a useful clue, isn't it? Okay. Then we'll look at the actual image. What we see here is that this is the right ear, and you notice it's not labeled here. That's because in this particular question, that's part of what's being tested. Okay. When you have a color audiogram, the right ear is always red, the left ear is always blue. So this is the left ear, this is the right ear. All right. Those of you that picked C, that you thought it was a conductive hearing loss in the left ear, if that was the case, what you'd see that this one here, the blue is the left ear. What you'd see is another blue line, but with brackets up here, showing normal hearing, and then that gap creates the idea that there's a conductive loss. What we're seeing here is what we typically see in a sensory neural hearing loss. They don't bother showing. They just show you the air conduction. They don't show the bone conduction because we're not really concerned about it. Okay, and in that situation, what you're seeing is just the two ears. So this is the right ear, rougher red, rougher right, and this is the left ear. Okay, and what you're seeing is that if you look at the line here, anything above this, so this is 20 decibels, anything above this is basically normal hearing. And what you see is the right ear, it's normal all the way up to here. Even this is on the normal line. Just at very high frequencies, it goes into very mild hearing loss. So do you see that fits with A, that the hearing in the right ear is mostly in the normal range, all the way up to here, it's normal. Whereas you see the left ear, even at low frequencies, there's some loss. And as you get to high frequencies, there's much more significant loss. Okay, so that's why A is the correct answer and why C is not correct. Okay, so this is normal. Anything above this, normal. This here is mild loss, and then this goes into more moderate and then severe loss. So what to look for in the image? Bone conduction will be shown by brackets where it's shown. Air conduction will be shown with a cross for one ear usually and a circle for the other ear. Easy way to remember that air passes through a circle. So here's an example of a conductive loss. In this case, the conductive loss is in both ears. So you see the red, that's the right ear's bone conduction. B for bones, B for brackets, okay? Sometimes there'll be triangular brackets like this. Sometimes it'll be square brackets like this. And then this here blue is the left ear's bone conduction. You can see both right and left, the bone conduction is normal for this patient. Then what we've got here is mild moving into moderate loss for conductive loss. And where there's that gap between the air conduction and the bone conduction, that's what tells us the conductive loss, because this is air conduction, okay? And then this is what you see typically in sensory neural hearing loss. They often don't bother showing the brackets because we don't really care about the bone conduction, all right? So what we've got here is, this is the red, so right ear, and this is the blue, so left ear. And anyone know what type of hearing loss is being shown here? Type into the chat. This particular image is very typical of a specific type of sensory neural hearing loss. Which type? It is very typical of presbycusis, the hearing loss of old age. It's often bilateral, and it's the high frequencies. If you look here, low frequency, this is actually normal. Then you get mild loss. Once you get into the high frequencies, 6,000 kilohertz and above, it's a quite significant loss. We've got into severe loss here, haven't we? Okay, even at 4,000, it's on the border of moderate to severe. Then it goes into severe once you go above that. So this is very typical of presbycusis, the hearing loss of old age. Okay. Okay, question number 2, men's health. Okay, please select an option if you haven't already done so. And I'll stop you there. Now, before I go through what is the right answer, you can see it's a really long question, and that brings challenge. The other thing that brings challenge to this question is an example of a 2-step question. The question is asking about the most suitable management option, but you see, to work out the right management, you need to find out what is the likely diagnosis. And so that's the first step, right? The first step is working out the diagnosis, and that gives you the second step, which is the most suitable management. So let's double the learning and look at what if this question was asking, instead of what's the most suitable management, what if it said what's the single most likely diagnosis? Type that into the chat. What you think is the most likely diagnosis from this presentation. I'll give you a few seconds. Great. Most people have picked the same thing for what they think the diagnosis is. They think that it's epididymoorchitis or epididymitis, okay? That's the most common by like a big margin. We've got a few other things that people have thought about. So some people have thought about things like acute prostatitis. Sometimes people think of things like torsion, but almost everyone has picked epididymoorchitis. That's the first step. Once you've got that, then that makes the second step much more likely. Okay, so the correct answer is D. Treat with levofloxacin for 10 days. Okay, now let's look at how this presents and then which variant this is. Then we'll look at why, those of you that pick some of the other options, because A and B were also very popular. D was the most popular, but A and B were also popular. We'll look at why they aren't correct. So epididymoorchitis typically has a gradual onset. It's painful. It's tender to palpate. There's a swelling when you palpate. There's erythema overlying. And one of the really useful clues, if we go back here, is that Pren sign is positive. Okay. And this patient, no recent sexual activity, recently treated for a UTI. Okay. But this is really useful. This is very useful to separate if you think it might be torsion compared to epididymoarchitis. So Prensine is where you elevate the scrotum, thereby elevating the testes, and that relieves the pain. That's Prensine positive, which is what you see in epididymoarchitis. In torsion, the pain is not relieved. Okay. So now, in terms of managing it, if the patient is like almost septic, really severe symptoms, they're very systemically unwell, high fever, you might need to admit because they might need IV antibiotics. Otherwise, in most cases, either we can treat in GP, or if they can get seen by GU medicine within 24 hours, it can be managed by them. Because it's difficult sometimes to get an appointment that quickly, in a lot of cases, this is managed in the community by us. So you treat based on the likely cause. There's two predominant variants. So one is related to an STI, commonly things like gonorrhea, in which case, ceftriaxone would be important. You can also use doxycycline. You can sometimes use azithromycin as well. Sometimes a lot of people who've got gonorrhea, there might also be a risk of chlamydia, for example. This patient hadn't been recently sexually active, right? And so that was unlikely, and they had recently had a UTI. So the other major variant is enteric organisms related to UTI. And for those patients where there's a low risk of STI, then you can use ofloxacin or levofloxacin. They're both long courses. So ofloxacin is a 2-week course. Levofloxacin is a 10-day course. So if I go back to the scenario, you see those that picked A, which is about a fifth of you, if you thought it was torsion, then that made sense why you'd think admit to hospital for surgical management. But the fact that Prensine is positive and this patient's age makes that a lot less likely. If this patient had recently been sexually active and you thought it was the STI variant, then ceftriaxone and doxycycline might be sensible if you thought it was an STI. This one option C highlights the importance of not just having knowledge. So a lot of you might have known that you can use ofloxacin or levofloxacin for the enteric variant, but you might not have read carefully. So exam technique, reading carefully. Look at this. Treat with ofloxacin single dose. While 200 milligrams is the right dose, it's not a single dose. It's 200 milligrams twice daily for 14 days. So this single dose is going to do nothing. You see, it's very, very subtherapeutic. That's a homeopathic dose, right? Then D is the right answer. And then E, again, azithromycin. If you were thinking about STI variant, you might be thinking about that. Okay, question number 3. Okay, I'll stop you there. Again, there's 2 steps to this, right? So the question's asking about management, specifically according to the fever pain criteria. And so the first part is calculating the fever pain score. So let's do that too. Type into the chat, what is this patient's fever pain score? And again, that might change what answer you picked, why you thought it was a certain answer rather than another. So the 2 popular answers, by the way, are A and B. No need for antibiotics or offer a delayed script for PenV. So we've got scores ranging from 0 is the lowest. Lots of people have picked 2 or 3, and then some people have picked 1 as well. So we've got 0, 1, 2, 3. Okay. This patient's fever pain score is 3. Okay. So first thing is they've had a fever within the last 24 hours. You can see, although they're afebrile now, the fact that it's within the last 24 hours, this was early in the day, and patient reported, or in this case, parent reported temperature's fine. Okay. So fever within the last 24 hours gives you 1 point. Then fever pain, right? The P is for pus on the tonsils, purulence. There's no pus, so there's no point for that. So we're still on 1. A is for attending rapidly within 3 days of symptoms. They've had symptoms for 2 days, so they get a point for that. We're on 2 so far. I is for inflamed tonsil. So even though there's no pus, there's inflammation. If they had pus, that'd be another point, right? So inflamed tonsil, that's 3. Okay. And then N is for no cough or coryza, i.e., they don't have a runny nose or a cough. If they have either one, then if they've got a cough, if they've got runny nose, either one, they don't get the point. You only get a point if you've got neither a cough nor a runny nose, but they've got a runny nose, so they don't get a point for the N. So the score is 3. Okay. So once you know that, then it's straightforward, because in terms of management, if they score 0 or 1, then the NICE guideline says no antibiotics needed. 2 to 3, consider delayed script. 4 to 5, consider antibiotics. This is the actual fever pain criteria. All right. In the NICE guidelines, they mentioned this. They also mentioned you can use Centaur, which got slightly different scoring. But that's why the question specifically mentioned using the fever pain criteria. Okay. So you can see because their score was 3, a delayed script is the correct answer. Okay. And if we go back to the options, most people picked either A or B. So the likely reason those who picked A is that you miscounted some of the things and had a low score, and that's why you thought no antibiotics. But 0 or 1 is no antibiotics. They were 3. If they had one more, if they got to 4, then actually would start antibiotics today. Okay. And then the option of clarithromycin, that would be if someone had an allergy to penicillin, then clarithromycin or erythromycin can be used as alternatives. But this patient, there's no allergy mentioned, so it's not relevant. Okay, admin domain, health records. Okay, great. So really happy to see that most people got this right. Most people picked the correct answer, which is E. And the key thing about this one is that this patient is not trying to access their own information, their own record. They're trying to access their father's record, and their father's passed away. And that's exactly what the Access to Health Records Act 1990 is for. It's to allow the next of kin or someone with a legitimate interest, like the executor of the will, to access the records of someone who's passed away. Generally, that's because they think there might be negligence, and they want to take legal actions. They want to look at what was documented. Okay. Whereas if someone wanted to access their own information, which act would they apply under? Type into the chat. Let's say you wanted to get access to your own information, maybe from a hospital where you've been seen. That would be the Data Protection Act 2018. That's the really common one. And some of you might have picked that just because you're familiar with it. But it's important, again, to read the question carefully. This patient's not trying to get their own records. They're trying to access someone else's records who's passed away, and they've got a legitimate interest. You can see they're both the next of kin and the executor of the will. Okay. So 3 important bits of legislation in relation to health records. So the Data Protection Act 2018 is what we use if we want to access our own information. The Access to Medical Reports Act 1988 allows companies that want to access information about their employees, usually in relation to occupational health, that has legislation and lays out the rules around that. And the Access to Health Records Act 1990 is for this situation. If someone wants to access someone else's records who's passed away, but they have to have a legitimate interest. Okay, last one before we move on to the mini-mock, data interpretation. Okay, great. So you see, this kind of data interpretation question uses real life data. This is real life data I've pulled from Public Health England. And we're looking at different parts of Yorkshire. We've listed various parts here. It's actually part of the graph. I took a snapshot of it. And the key thing is reading which data they want you to actually pull out from what's shown. So it's the worst mortality rate for women under 75. So you can see here, we've got mortality rate for persons. That means male and female. Then we've got just the male. Then we've got just the female. Right? Underneath here, this is a subset of this. So mortality rate, if it doesn't say what condition, then that just means crude or general mortality. It could be death for any reason. It could be cardiovascular. It could be cancer related. It could be an accident. It could be anything, trauma. Whereas these are only people who had a cardiovascular related death. So maybe heart attack, stroke, heart failure, something related to cardiovascular disease. All right. So what we want to look at is this line here, mortality rate for women under 75. And so that's here. And then it says the worst mortality. So which is worse, a higher or lower number? Higher is worse, right? Mortality rates are deaths per thousand. So look, Doncaster had 324 deaths per thousand in these group under 75s who are female. Now, most of you got this right, but of those that didn't, the most popular answer was B, Bradford. So why might people have picked Bradford? Well, if you look at Bradford, if you look at male and female, they have the highest rate, higher than Doncaster. If you look at just males, they've got significantly higher than Doncaster. Okay. Similarly, if you look at even in females, but if you look at just for cardiovascular disease related mortality rather than mortality for any reason, Bradford has a higher rate than Doncaster. So those are the reasons why people might have picked Bradford, just not picking up that we're looking for specifically women under 75 and mortality for any cause. So, if you looked at men, or if you looked at persons, male and female, or if you looked at just cardiovascular diseases, even in female, you would have got the wrong answer. So reading the question carefully and then interpreting. So what other types of data interpretation questions can come up? So they could include things like prescribing data about things like antibiotics or benzodiazepines, regional disease incidence and prevalence. So prevalence of different types of cancers, for example. It might be that in certain areas, there might be higher rates of things like COPD. If you were in a town where there was a large amount of the population that used to work in the mines, think about certain conditions that they might be at increased risk of, lung-related disease. So these are generally drawn from public health data. So it could also include things like mortality rates, so infant mortality, cardiovascular mortality, all-cause mortality. But then you can also get graphs and charts looking at interpreting research. So I'll give you some examples. This is looking at different age bands and the proportion of patients in this particular surgery in different age bands. This graph is looking at antibiotic prescribing for broad spectrum antibiotics, which is often used as a quality marker on good antibiotic stewardship. Right. It's an example of a quinary graph. So it looks at 5-year age bands and what proportion of patients, male and female, are in each of these age bands. This is looking at infant mortality. Okay. This is called a leaf plot. It's a way to look at the pre and post test probability once you've got a result. It's called a Kate's plot. It's a visual way to represent risk and discuss risk with patients. Okay. So those are some of the types of things that it's important that you know how to interpret. All right. Any questions before we move on to just a reminder about our masterclass webinars, which are kicking off this weekend, and then we're going to move on to the mini mock. Okay, so our AKT masterclass webinars, just how we've done there, where we do one question at a time, then go through the answers, explanations, but also look at why people might have got the answer wrong, so you can start improving your technique and understanding the reason why. That's exactly what happens in our masterclass webinars. So they run live, but then you also get access to the recording afterwards for a month for revision. So it's very interactive. You get engaged, like you've been doing with the chat, like you've been doing with the polls. So we have 4 of these. Statistics made simple, 4 hours covering key stats, topics, graphs, charts, including all those graphs that I showed you just now. That's going to be this Saturday in the morning. The organizational domain organized. So key admin topics, again, in that same style, that's 4 hours, again, this Saturday, but in the afternoon, 2:30 to 6:30. And then clinical grammar, there's so many topics to cover. We split it into 2 long evenings. So that will be running next week in the evenings, 7 p.m. to 10:30 p.m. So 3.5 hours, 2 evenings in a row. So 7 hours of content to cover all the clinical topics mentioned by examiners in recent examiner reports. So, exam style questions followed by rapid reviews. So you can book any one of these, or you can book all of them at a huge discount. So these are £125 each. These are 198 for both of them. Or if you book all 4, it's £299. So that's a £149 discount. And if you're not available on any of the live sessions, you could join some live and then get access to the recordings after, or you can just subscribe to the recordings directly. So these are all the topics that will be covered at Stats and more. And you can see we've helped lots of people that some of them didn't really like Stats before, but then they went on to get like 100% in this case, 100% in this case, 95% in this case, 90%. This was something that they felt was a weakness before. And these are some of the topics that will be covered at the admin. And again, lots of people that have got fantastic scores in admin, 95 here, 95 here, 90 in organizational, 95 in organizational. And these are the topics that will be covered, some of them, at the clinical grammar. We'll actually cover over 100 topics in the clinical grammars, and over 50 topics for stats, 50 topics for admin. Great, time for the mini mock. Okay. So we're going to do 10 questions. Now, here we did one at a time, and then I went through the explanations. In this situation, I'm going to run all 10 questions without stopping. There'll be no polls. After 55 seconds, whether you're ready or not, the questions will move forward automatically. I want you to get used to the pace of committing to an answer, but also, sometimes you have a question that throws you or you find challenging, the importance of clearing your mind and not letting it get to you and being able to focus on the next question. Okay, so we're going to go straight into it, and then the questions will move forward every 55 seconds. Here we go. Okay, well done, everyone. Okay, great. So let's go through the answer and explanation. So I won't be launching polls for these now. We're just going to go through, I'll remind you of the question, tell you the answer, go through the explanation so we can get through all 10 of them and then still have time to talk about what to do between now and the exam the next 8 weeks. So in almost every AKT, there will be a cancer pain type related calculation like this one, and usually also a pediatric dosage calculation. There always has to be at least one drug calculation question, but often there'll be one of each of those types. So, this is an important area. So what we've got is that this patient at the moment on morphine sulfate MR, modified release, 120 milligrams twice daily. So that's 240 in total. That bit's important. Sometimes people miss that. And they're well controlled. The reason that they can't continue this is that they're just not able to take oral anymore due to their illness. So what we need is, this is a good candidate to change over to a non-oral form. So in this case, we're thinking about moving them to a syringe driver. That's quite commonly used, especially in palliative care when someone gets nearer to the end of life. Okay, so what's the conversion? The correct answer is C, 80 milligrams over 24 hours. That's because when you convert from oral morphine to a syringe driver with diamorphine, it's 3 times as powerful. So 120 times 2, that's 240. Divide by 3, that gives us 80. The common mistake here that people do is that they miss that it's twice daily. So they do 120 divided by 3 and they get 40. Or they get that 120 twice daily, so 240, but they divide by 2. If you divide by 2, that's if you were changing to morphine by injection rather than diamorphine. Because morphine by injection is twice as strong as oral morphine. Diamorphine is 3 times as strong. So you calculate the 24-hour oral morphine requirement, including breakthrough doses if they've needed it. Then if you're converting to morphine, divide by 2. If you're converting to diamorphine, divide by 3. Okay. Question number 7. So genetics. We've got both parents here are carriers for hemochromatosis. Type into the chat, what's the mechanism of inheritance for hemochromatosis? It's autosomal recessive. Great, okay. So in this case, what they're asking is, if they have any children, what's the risk that they'll have disease? Not be carriers, but have the disease. So if both parents are carriers, the risk of their children having full-blown disease is 25%, because they'd have to get the faulty gene from mum and dad, and that only happens in 1 in 4 times. The second one in the set, so this is an extended matching question. They come in sets, right? So this is the second one in the set. They'll have the same answer options, but a different scenario. So in this case, the scenario is, they're not asking what's the risk that their children will have the disease, but will be like them, carriers. So what's the risk of becoming a carrier? If both parents are carriers, your risk is 50-50, you become a carrier. So the correct answer is D, 50%. And this is true of other autosomal recessive diseases. Okay, so look, mum's got a hemochromatosis gene and a normal gene. Dad's got a hemochromatosis gene and a normal gene. That's why they're both carriers. So you get one from your mum, one from your dad. If you're unlucky, you get the hemochromatosis from your mum and from your dad. Your HH, you have full-blown disease. You see, that's only going to happen 1 in 4 cases. If you get one from your mum and a normal one from your dad, or one from your dad with hemochromatosis and a normal one from your mum, 50-50 chance that happens, you become a carrier. Then 1 in 4 will be lucky. They'll get the normal gene from mum and the normal gene from dad. Not only will they not carry it, not have disease, not be a carrier, but consider they're not going to be passing it on to the next generation either. So for autosomal recessive, 50%, if both parents are carriers, 50% you become a carrier, 25% you have full-blown disease, 25% you're a healthy non-carrier. It's also worth knowing the modes of inheritance of some of the relatively more important or common conditions for the UK population. So autosomal dominant, we've got things like neurofibromatosis, Huntington's. Autosomal recessive, things like cystic fibrosis, PKU, we test for in the newborn screening program. Alongside hemochromatosis, also things like sickle cell anemia are important. Then I've listed some of the other important ones to be aware of, and don't forget the chromosomal conditions. Okay, oligomenorrhea. So again, this is a 2-step question, right? And this one, there's 2 things that make this challenging. It's a multiple best answer. I can see it says which two. So you need to get them both right to get the mark. If you get one right and one wrong, you get nothing. And it's negatively framed, which is uncommon in the AKT. Most questions are positively framed. Because it says which two would not be recommended as part of the diagnostic workup for this particular patient. So again, it's a two-step question in that you've got to think, what is it that we're trying to diagnose them with? What is the workup looking for? Okay. So some really important things in that. They're 38 years old. They've been having erratic periods for a year, but they're still having periods. That's important. You can see sometimes it's 6 to 8 weeks, but then had no periods. Then they started it back again. So very variable, very erratic. And then she's got additional changes. Mood changes. Recent sneers okay. She's not on any medication, otherwise healthy. So there's changes in the mood and changes in the period. So what do you think the diagnosis is, first of all? Type that into the chat. Taking all those factors in, including the age, is really important. So some people have suggested it could be perimenopause, could be PCOS, it could be premature ovarian insufficiency or premature ovarian failure, sometimes described as. Okay, now you see, that's important that you think about that, because that's going to help you decide the test. So the correct answers, first of all, of what would not be. So the diagnosis is premature ovarian insufficiency. Okay, she's under 40. That's a really important part of that. All right. Whereas if she was much older, then we might be thinking about perimenopause. Okay, but because she's under 40, that should be what we're looking for here. And so what would not be recommended as part of the diagnostic workup? A pelvic examination and anti-Mullerian hormone. Now, most people pick AMH, but what happens is a lot of people, the second one, they don't pick A, they pick one of the other ones. Now, sometimes that's because of knowledge. You might not be familiar with the guideline. Sometimes it's missing that it was negatively framed. It asks what would not be recommended. Okay. So there's not an indication to do a pelvic examination. The guideline specific says that we shouldn't routinely perform that because they're otherwise healthy. They haven't got other symptoms that make us worry. For example, she's not had a sudden loss of weight, making us think that could be a cancer or something like that. So, doing unnecessary pelvic examinations can be traumatic to patients. Okay. If there's not a good clinical reason to do it, you shouldn't be doing it. So when to suspect premature ovarian insufficiency? Under 40, not on the combined oral contraceptive pill, and they've got sort of menopausal type symptoms. So that could be erratic, infrequent periods. Sometimes they stop and start back. Okay. And they might also have symptoms like mood changes, hot flushes sometimes, things like that. So what will we do in terms of testing? We're looking for FSH to be raised 30 or more international units per liter, 2 different samples, at least 4 weeks apart. And then other things that you might do: LH, estradiol, prolactin, TSH, testosterone levels. But the guideline specific mentions not to routinely perform a pelvic examination and not to use AMH testing as part of that diagnosis. Okay, question 10, admin domain. So key things here, that the family, rather than a patient directly, is the ones given the gift. The patient's passed away, and the family were really happy with the way it was handled. And so it's about the GMC's guidance on gifts. So which 2 are correct? B and F. That unsolicited gifts from patients or relatives may be accepted in some situations. We'll look at what the criteria that need to be met in order for it to be okay for you to accept the gift. But that in some situations, because some people have it in their head, you can never accept a gift. That's not true at all. The GMC doesn't say that. And those of you that have been working in GP over a Christmas period, you'll see it's really common if people have been with the practice for a long time, and maybe they've had, one regular GP that they see, and especially if they or a family member went through a significant illness and that GP made the diagnosis and admitted them to hospital, or, helped them to get through something, you'll often see that it's really common for people to give gifts around Christmas. All right. And as long as certain criteria are met, it's okay to accept gifts. And then F, that there's no maximum value that the GMC set in terms of a gift that can be accepted. Again, some people get in their head that because they've seen the number £100 somewhere, that's nothing to do with GMC guidance. If you are in a practice that has a GMS contract. GMS is General Medical Services. It's the most common NHS GP contract. That does specify that if you accept a gift with £100 or more, that it needs to be reported. They don't say that you can't accept it, just that you need to record it in a register of gifts. Okay. But the GMC doesn't specify any value. So B and F are correct. You need both of them right to get the 1 mark. So GMC guidance says you're not allowed to encourage patients or family members of patients to give you a gift. You can't pressure them to give a donation, even if it's to charity. You're not allowed to alter the management or the services that you offer based on gifts, because then it's a bribe. You shouldn't accept a gift if it would be seen as a conflict of interest. So like you've got someone with advanced dementia, taking a gift from them might be seen like you're taking advantage. But if none of those are there, and none of those applied in this case, and they voluntarily offer a gift, you can accept it. And the GMC doesn't specify any maximum value. Now, if your practice is a GMS practice, which most practices, especially most training practices are, remember that's nothing to do with the GMC. It's one of 4 NHS GP contracts. That has a clause within it that if you accept a gift worth £100 or more, you have to record that in a register of gifts, which is kept at the practice. Okay, now this was highlighted. Chronic musculoskeletal conditions and rheumatological disease, generally have been mentioned in different examiners' reports. So, chronic musculoskeletal conditions was mentioned in the latest examiner's report, but rheumatological disease and diagnosis and management, and even things like for patients on methotrexate, drug monitoring, these have all been mentioned in different examiners' reports, an area that people often struggle with. So key things here is that this patient, the small joints of the hands and feet are what's affected. Okay, so we've given them something for the pain. We've ordered some blood tests, including things that we might look at, so that rheumatoid factor, ANA, double-stranded DNA, things like that, ESR. But the questions about the most appropriate next step, the correct answer is to refer to a rheumatologist within 3 working days. Don't wait for the test results. That's going to add significant delay. Anyone with suspected rheumatoid arthritis should be referred within 3 weeks. But there are certain categories who are at increased risk who should be referred to be seen within 3 working days, i.e. ultra urgent. So anyone with suspected rheumatoid, 3 weeks is like the maximum, right? But who to refer even more urgently? Within 3 working days, if the small joints of hands or feet are affected, see this patient, small joints of the hands and either one would warrant a very urgent referral within 3 working days. If they've got more than one joint affected, so sometimes it's not the small joint. Someone's got a knee and a shoulder, 2 different joints. That's within 3 days. Or if they've already had symptoms for at least 3 months, why? They're likely to already have significant disease progression. So the sooner they're seen, the sooner they can get onto disease-modifying anti-rheumatic drugs, because they're not things we can prescribe in primary care. Yes, we can give NSAIDs that will help with the swelling, will help with the pain. It won't reduce the progression of disease, will it? Okay. And so, and again, the guidelines specifically mention not to delay referral for blood tests that are normal or awaited. Even if you suspect it clinically, even if the blood tests come back normal, that doesn't mean you don't refer, and don't wait for them to come back. Don't delay the referral if they fulfill any of the urgent criteria. Okay, alcohol intake. So remember, in the exam, you have an on-screen calculator. Okay, so 1 large 250 ml glass of wine, and they've given the percentage alcohol by volume. They have that 7 nights a week. So every single night, Monday through to Sunday, they'll have a large glass of wine in the evening, in the night. But on Saturday and Sunday, they also have one at lunch because they're not working. It's a teacher. So the key thing in this question, there's 2 parts. So one is, how many glasses of wine is this patient drinking in total? Type into the chat. And then the other is knowing how to calculate units. Great. Can you see they're having 9? Because 7 nights, they have 7 glasses. And Saturday and Sunday at lunch, they're having another 2, right? 1 on Saturday, 1 on Sunday. 9 in total. That's important. And the other bit is, doing the calculation on knowing that a large glass of wine at a typical strength like this has 3 units in it. If you know that, then you can say 3 times 9, 27. So 3 units in a large glass of wine is typical. It's a typical strength, about 12%. The other way, if you want to be absolutely accurate, is to use the formula. So the formula is this. Units is the volume in milliliters multiplied by the percentage alcohol by volume divided by 1,000. So 250 mils multiplied by 12%, divide that by 1,000, that gives you 3. That's in each glass. And then they have 9 glasses. So 9 times 3, 27 units. Okay, I'll just show you that calculation, just so you can see it step by step. Okay, if I show you that look, they have 250 mils in one glass, right? So 250 multiplied by 12% alcohol by volume. So multiplied by 12, that gives you 3,000. Divide that by 1,000, that gives you 3 units in each glass. Times that by 9 glasses in the week, that's 27 units. Okay. Now, for a glass of wine, because glasses of wine can come in different sizes, they may well give you the exact volume like this. But what if someone has a pint of beer? They might not tell you how many milliliters that is, because they'd expect you to know how many milliliters is in a pint, because a pint is a common unit that patients would use. So type into the chat, how many milliliters is a pint? See, in the UK, we use imperial measures for some things, and we use metric measures for other things, right? So, we use pints in some cases. That makes it a bit difficult, right? Because it's not an even number. It's actually 568 milliliters in one pint. Okay, 568 milliliters is one pint. So now there's 2 ways to go about dealing with questions like this. And this is an area that's been highlighted as a problem area by the examiners. So one is just to learn how many units roughly are in common unit and then just estimate. So wine at about 12%, which is a typical strength. You get some that are stronger, some that are weaker. A small glass is 125 mils. That's about 1.5 units. Medium glass, 175 mils, about 2 units. And a large 250 ml glass, about 3 units. Now, if it's stronger or weaker, they would usually give you the percentage alcohol by volume. And then, you can use the calculation to get it exact. So I've given you the formula there. Standard strength beer, somewhere between 3.5% and 4% alcohol by volume. A pint of that's about 2 units. Premium beers and lagers, 5 to 6% strength. A pint's about 3 units. Spirits, 25 mils of any spirit at 40% alcohol by volume, which is the most common strength of spirits in the UK, is 1 unit. And then cider is often quite strong. A pint of a typical cider is about 3 units. But if you want to be precise, you've got the formula there. Okay. Number 13, so diabetes management. This has also been featured in recent examiners' reports as an area that causes difficulties. So you've got someone who's already on triple therapy, metformin, sitagliptin, and pioglitazone, and the HbA1c is still not well controlled. It's 70 millimoles per mole, well above threshold. What's the threshold when we generally think we need to move to the next step? Anyone know? Once it hits above 58 millimoles, right? 58 millimoles, we start thinking about going to the next step. Consider they're well above that, 70. Okay, so that's why we're thinking about insulin. So what would be a suitable initial regime? That's an important word, initial, the starting regime. Correct answer is B. NPH, neutral protamine hagedorn insulin. That's an intermediate acting insulin, and continue the metformin. So you'd stop the sitagliptin and the pioglitazone. They've still got the metformin for some cover throughout the day, and then there's a couple of ways you can start this. So like generally, if I'm going to start someone on this, I will put them on once daily in the evening, continue their metformin, stop the others, and then see how they get on. You measure the blood sugars twice a day, once in the morning, once in the evening. If their HbA1c had been 75 or above rather than just 70 is still high, but 75 and above is even higher risk, then you might go straight to NPH and a short-acting insulin as well around meal times. Okay. When would you consider a long-acting rather than an intermediate-acting, like detamir or glargine? These are long-acting ones. If they need help with injections, or if they have recurrent hypos causing symptoms, significant hypos. And one of the reasons we need to monitor blood sugars is some patients may start with something like this, then move to having to also have a shorter acting insulin around mealtime, and sometimes around every mealtime, sometimes maybe around 1 or 2 of the meals. Right, type your answer. This is an example of a free text question. There's no A, B, C, D, E. So in the exam, you would type your answer. So type your answer into the chat. Let's see what people had. Now, by the way, this is real data. Again, I pulled from Public Health England on COVID-19 cases and related deaths in 2020. Okay, so we've got answers ranging from 4 to 0.04 to 87% to 40 to 41,560 and various things in between. Big range, okay? So the correct answer is 41,560. So this is the only answer that would give you the mark. If you type this, 41,560. The reason for that is it says to the nearest whole number, but also it's asking for the incidence per million. And why is it asking like that rather than as a percentage? Like if you put the percentage, you wouldn't get the mark for this question. We can quote incidence as percentage. It often is quoted for some conditions as a percentage, especially for common things. It's often quoted. But this is where, again, reading the question is really important. The reason that it would be asked in this way is the WHO asked all countries to record the incidence and report it per million so they could compare one country to another when you've got, it was a global pandemic, right? It was going on in every country pretty much, okay? And so that's why it's standardization. So let's look at the steps. First of all, incidence is the number of cases divided by the total population. So we can ignore the deaths. Whereas if you ask for COVID-related mortality, then we'd look at this number. But this number is not important. So we want to look at the incidence of cases, 2,770,000 divided by the population, which was given to us, so 66.65 million. Okay, that gives us this figure. Now, those of you that then turn that into a percentage, you turn that into a percentage by multiplying by 100. So you'd move this 2 places. You see, you'd get 4.15%. And those of you then rounded that to 4%. As a percentage, that's correct, but it asked the nearest whole number, not a percentage, okay? In terms of per million. So do you know that percent just means per 100? In the last step, after you've done this, to get it per whatever, per 100 means percent, you multiply by 100. But if it's per million, you multiply by a million. So when you multiply this by a million, you get 41,560.39. Now, to the nearest whole number, what you do is look at the number after the dot. This number, if it's 4 or lower, then this is the nearest number. If it's 5 or greater, you'd add 1 here. So if this was 41560.51, for example, then it'd be 41561 to the nearest whole number. But as this number is 3, i.e. it's 4 or lower, then the nearest whole number is this number here, i.e. we just don't look after the dot. So 41,560. Now, if you type that without the comma or with the comma, doesn't matter. You'd get the mark. But if you put a percentage at the end, or you got 4%, or you got, anything other than this number, 41,560, you wouldn't get the mark. Okay. So incidence is the rate of new cases of a disease. How many cases happened in that year divided by the total population. Generally, we look at it over a year, but you can look at it over a longer period. But generally, we look at it over a year. So like 1% per year means 1 in 100, because percent just means per 100. Now, if you want to look at it per 1,000, in that last step, you multiply by 1,000. Like mortality, we generally look at per 1,000. All right. If you want to look at it per 100,000, you multiply by 100,000. In this case, per million, so you multiply by a million in that last step. So you do new cases divided by the population. And if you want it as a percentage, percent means per 100, so multiply by 100. You want it per 1,000, multiply by 1,000. You want it per 100,000, multiply by 100,000, and so on. Okay. And last one, prescribing in pregnancy. Now, this is an important question because the examiners highlighted in recent reports that they will often look at recent MHRA reports. MHRA is the Medicines Healthcare Regulations Agency. They put out drug safety alerts about, when you fill in the yellow card, you send it to the MHRA if someone's had a significant side effect to a medication. And they monitor these from everywhere. They get these reports to look for trends. And they say, oh, you know what, this drug is causing this new problem we didn't realize or wasn't picked up in initial trials. We're going to put out a drug safety alert about it. And there was a recent one about NSAID use in pregnancy. So the correct answer is D, that they advise additional antenatal monitoring might be required if someone's used NSAIDs from week 20 onwards, whereas previously it was 28 weeks onwards, we'd say not to use it. That was always contraindicated in the last trimester, 28 weeks onwards. But this latest data shows that even earlier than we previously thought, that people were having problems. And that's why this alert was put out. Okay. So they're contraindicated in the last trimester. So 28 weeks onwards, the reason is that it can cause all of these problems. Premature closure of the ductus, renal dysfunction, can increase the maternal bleeding time. It can cause problems with contraction, which can prolong the labor, make it more challenging. And things like ibuprofen, naproxen, diclofenac, oral or injections, they should be avoided. But this latest data highlights that if you're using even orals, over-the-counter ibuprofen for prolonged periods from 20 weeks onwards, it can cause some of these same problems. But it can also, one of the things to watch out for is things like reduced fluid, oligohydramnios, because it can affect the baby's renal function. We know that NSAIDs can affect renal function. It can also cause that issue that we know about the premature closure. It can cause, rather than full closure, it can cause constriction, which can lead to heart dysfunction. And so that's why this alert said to consider antenatal monitoring, especially for oligohydramnios, if the mother was exposed to NSAIDs for several days. Imagine someone had, for example, hurt their knee or something like that. They might take 4 or 5 days of NSAIDs over the counter. We might not have thought to ask about that. We should be asking about that. And we shouldn't be prescribing it at all and advise them not to take it over the counter. Okay. So add up your total. We get a number out of 15. So 11 or more would have been a pass in any sitting historically of the AKT, because that would be above 72%. Now, if you got 11, 12, 13, 14, that's good. But look at the ones that you missed. Was it a lack of knowledge? Is it a guideline you haven't covered? In which case you can cover it. Is it technique? Again, you can work on that. If you got 10, that's borderline. In some exams, that would just miss the pass mark. In some, it would just be on the pass mark or just above it. So again, look at where did I lose the other 5 marks? And then 9 or less, you're not there yet, but don't worry. You're not sitting the exam tomorrow or even next week. We've got 8 weeks to the exam. Okay. So look at what can I improve? Look at this as a learning opportunity, which is exactly what it is. So let's talk about revision planning for the last 8 weeks. So at this stage, you should already have covered a good chunk of the curriculum. What you need to do is systematically cover the rest of the key curriculum topics. And any weaker areas in the curriculum, you might need to go over more than once. You want to make sure you've covered the key stats topics, admin topics, and higher clinical. The last 30 days before the exam, we'll run the AKT 30-day challenge. I have a video every day. They're available on our YouTube channel as well. We'll go through, a question like we did here, 55 seconds, then answer, explanation, rapid revision of the relevant guidance and topic. And work on your exam technique by continuing to practice questions and doing some timed mocks, especially the last month. I recommend doing 1 mock every week in the last 4 weeks running up to the exam. We've got a checklist of all of the important topics in the curriculum. Make sure you've ticked them all off before you get to the exam. There's about 600 topics listed there. And then our high yield topic checklist. After each examiner report comes out, I analyze it, and then I look at any topics they've presented. They now present it in a much more user-friendly way. They give a list of the topics that they considered important from the latest exam. Whereas previously it was to be all written in like a paragraph form. You had to pick them up. They actually just give a list. So I've updated this since the July report came out. So it's bang up to date now. And what's interesting is from the last year's worth of reports, there are only 2 new topics that I had to add. All the other topics were already on my list. Okay, this is only part of it. There's another page with more topics in alphabetical order, but you'll be able to download that in the post-course reading links that I'll send you. Okay, and in terms of reading guidelines, the exam is based largely on national guidelines. Okay, just a note about this, by the way, is that sometimes people use things like NICE CKS because it's more concise. CKS don't write any guidelines. Okay, they summarize the NICE guidelines, and sometimes there are differences between what CKS says and what the full NICE guideline says. The exam will always rely on the full NICE guideline rather than CKS, because sometimes CKS might be 6 months, a year behind the full NICE guideline because someone's got to summarize. All right. Now, if you want to look up a specific guideline, you can access it on the NICE website. You can search for it. If you want to cover lots of guidelines quickly, our clinical case cards are updated annually. So the latest edition is from 2014. Okay, it's a quick way to read up on lots of topics. And then, you know how we did the mini mock, 10 questions in a row, and then we went through answer explanations? Our AKT 200 mock crammer is going to be happening after the masterclass webinars, the stats admin and the High Yield clinical crammers run. It will happen a couple of weekends after that. And it's in that style, but rather than a 10-question mini mock, it's a 50-question mini mock in one go. Then we go through answers, explanations, and I give you a topic review to download. Then you have a break. Then we do another one with 50 questions. Then you have your lunch break. Then another one, then break, then another one. So by the end of the day, you've done 200 questions. Each 50-question mini mock has 80% clinical, 10% stats, 10% admin. So by the end of the day, you will have covered 160 clinical topics, 20 stats, 20 admin. They've got a big proportion of high yield topics within them, but it also gets you used to managing your time. Okay. And after, you get access to another full 200-question online mock with 200 completely different questions to make sure that you've applied what you've learned, go away and fill in any gaps, and then do that as a readiness. Those of you on our Pass Guarantee program, you're already registered for this. You'll also be doing this full mock as part of your scheduled mocks that we'll be doing. Okay, those of you on our Pass Plus, you'll also be part of this. And this is also available as part of one of our other bundles. So we've got our Pass Plus bundle. That includes our full day AKT course, which we ran last weekend. So you could access the recording of that. The AKT 200, our stats webinar this coming weekend, the admin webinar, the 2 high yield clinical webinars, over 2,700 online AKT questions, including 3 full mocks, and the case cards. It's about 130 odd hours of learning. Okay, significant discount compared to if you were to buy all of these separately. The booster bundle includes all of that except for the full question bank. It includes 1 mock, and it includes the doesn't include the full day AKT course. So it's the AKT 200 and the 4 masterclass webinars and 1 full mock. And then the masterclass bundle is the 4 webinars: stats, admin, high yield clinical. So all of them are significant saving compared to if you bought them separately. But this one offers the biggest saving. Okay. Right. Any questions that haven't been dealt with, we'll try to clear up in the Q&A. And then for anyone that hasn't got questions, let me leave you with this as we get to these last 8 weeks. That, as Muhammad Ali said, don't count the days, make the days count. Make sure these next 8 weeks, every single day, don't let a day escape you that you've not progressed your learning, whether that's revising 1 guideline, doing 1 batch of questions, doing, looking over some notes that you made earlier, making sure you've learned 1 high yield topic. Just every single day, you've got to make sure you get something out of it. And then as you get to the last month, you need to intensify it even further if you want to, make sure that you're exam ready. So don't just count the number of days, make every single day count. And if you can do that and you put the work in and you keep up your hard work, then prepare and you will succeed.